Good afternoon, ladies and gentlemen. If you please take your seats, we're going to get started in a minute or so. I'm going to do roving interviews for this one, is that all right? Are you good, Rumbi? Do you want to go over and meet your panelists? You meant Vivian, Margaret, great. Good afternoon, everyone. Welcome. My name is Richard Jones. I'm editorial director at Devex and delighted to open today's session, Stepping Up to the Challenge, Scaling Up Local Solutions to AMR. I'd like to thank you all for joining us. It's a very timely discussion. We're coming together to address one of the most urgent and complex public health threats of our time, antimicrobial resistance, or AMR. Now, as many of you are aware, AMR isn't just a distant threat on the horizon. It's a crisis that's already here. It's affecting millions of lives around the globe. So the misuse and overuse of antibiotics in humans, animals, and plants are contributing to the rise of drug-resistant pathogens, making once treatable infections harder and sometimes impossible to cure. According to the WHO, AMR is directly responsible for 1.27 million deaths annually, with an additional 5 million deaths linked to this silent pandemic. The burden is felt most acutely on the African continent, which is on track to bear the highest burden of AMR-related deaths by 2050 if we don't act urgently. However, there is some room for optimism, and today we're here to discuss solutions, local solutions, that can be scaled up to meet this global challenge. So in partnership with GSK and AmrefHealthAfrica, today's event will focus on a number of things: how community-led efforts are crucial in combating AMR, and how these solutions can be scaled up and replicated across the African continent. We're going to examine the critical role of primary healthcare and the health workforce in responding to this crisis. And we're going to spotlight the importance of multi-stakeholder partnerships in building the capacity and the awareness needed to address this AMR crisis. As we look ahead to Thursday's UN high-level meeting on AMR, we really find ourselves at a pivotal moment. So let's get started. And without further ado, I'm going to welcome to the stage my colleague, Alex Cabaret, Vice President of Partnerships at Devex, and his first guest. A big round of applause, please.
Thank you so much, Richard, for setting the scene. You've done a great job. And please come on stage, Yewande and Fiona. Welcome on stage. I was about to say welcome on board, but we're not on a boat. Maybe we took too many planes recently. But thank you so much for being with us. We're very, very happy to have you here. So you go by Wande, so we'll do that. So everybody, now you can refer to Dr. Yewande Alimi as Wande. She leads the AMR effort with the African Union and is also the One Health Unit lead at Africa CDC. You have you're a doctor of veterinary medicine, and you have a master in public health as well, right? So you know these issues quite well. You get to work on them every day for the Africa CDC. And as Richard explained, the burden is higher in Africa. The responses that we're talking about for AMR, a lot of investments go to already I would say mature markets, but less in Africa. So we're looking at solutions today. And Fiona is VP of Global Health at GSK, correct?
Correct.
Right, and working on a lot on science innovation and R&D in that space and enabling some of these partnerships. So thanks again for being here. So one day, I'll start with you, the question. So with all of this burden that Africa is facing, we'd like to know what your organization is doing and how you are trying to tackle this issue and the AMR and of AMR in the continent?
A really exciting session. I wasn't really expecting so many people, but really exciting that a lot of people are particularly keen to talk about a critical issue from the African continent. I think, first of all, it makes me really proud that we have people keen to see how we can control AMR on the continent. I really like to always start with this. In simple terms, AMR is easily one of the biggest threats the African continent faces. If nothing is done, we stand a chance of having over 4 million Africans die every year. In simple terms, I'm sure everyone knows HIV, TB, malaria. AMR is easily killing many more Africans than all of that put together. I work for Africa Centers for Disease Control and Prevention, which is the Africa Union's technical agency focused on AMR. And one of the things that has been on our priority since 7 years ago when we started was really what do we need to do to ensure that we save the African continent? And we are currently in a race against time. In a lot of conversations, we talk about excess use, overuse of antimicrobials on the African continent. But my colleagues and I think there are a couple of them in the room, I've tried to tell the African story. I think there are a lot of fundamental issues that really drive AMR on the African continent. I'll start with one is thinking about inequitable access to antibiotics, vaccines, as well as diagnostics. So I'll paint a picture for you. There's a physician currently in charge right now that is faced with a baby, and like a 1-week-old baby that has acquired an hospital-acquired infection. He doesn't have the right drug. He doesn't even have the right testing capacity. How is he supposed to make an informed decision? We call for improved surveillance. But across the African continent, the recent data that we published together with partners in 14 countries is only 1.3% of those countries that have sufficient bacteriology capacity. Means that practically everyone is forced to treat blindly. Um, so a lot of issues are quite fundamental, and it really is around tied to inequity. We argue that if we're able to ensure that the average African has, for example, the right access to laboratory capacity, the physicians can make an informed decisions. The veterinarians can make an informed decisions for treatment. But beyond that, sometimes the physicians don't even have the right drug. So how do we manage that? But most importantly, I think AMR remains a strong health system issue. If we're able to improve infection prevention and control and WASH, for example, which we have demonstrated that they're easily cost-effective interventions for a lot of LMICs, we will see value in reducing infection and subsequently reducing the need for us to use antibiotics. But most importantly is the fact that for the longest time, AMR has been sort of human health focused. We really need a stronger One Health approach to this, be it governance, resource mobilization, even the fact that we're thinking about regulations. We really need to take on a One Health approach. So simply put, Africa CDC has really tried to document the African story, telling the story from north to south, east to west to Central Africa. And we've tried to put that in a fantastic report, which was launched earlier, and we'll be spreading the message. It's really to say that, yes, there are challenges across the African continent, but there are clear recommendations in terms of what could potentially work for the African continent to reduce the spread of antimicrobial resistance.
So systemic approaches, patient-centered design. We talked a lot about this morning at another session as well, and then the renewed focus on One Health. So I know during the COVID crisis we talked a lot about One Health, and then it's kind of like stop talking about it. It's coming back up. So it's great to see that you're a specialist in this, and maybe we can come back to that after. And what you do, how do you work on this integrated One Health approach, given your background with in it's very hard for a French guy to say this.
Vet medicine.
Veterinary. Thank you. It's much easier when I repeat after someone. But okay, so maybe we go back to that. Fiona, I'd like to go to you next. So this has been called a silent pandemic for a long time. So why is it so important that we talk about it now, and how this happened? So what do you think from the GSK perspective?
I know it's been, well, I mean, it's not a silent pandemic. It's a pandemic that hasn't had the publicity, the coverage that it needed to have. So that's why I think.
Why is that?
Because there's no dedicated funding streams for AMR. You've not got kind of global coalitions behind it. You've not got visibility. I think AMR has always had a bit of a kind of perceptual problem, because it's easier to describe a patient with malaria than it is to describe somebody with AMR. So it's kind of been almost going on in the background. But and I think the other thing about AMR is it's tended to be the domain, from what I've seen, of kind of experts and scientists. It's not been owned as a community problem, as a family problem, as an animal problem. And I think that's one thing that seems to be changing a bit now. And you talk about One Health, but also with the high-level meeting on Thursday, it seems to be bringing all of these elements together. And actually, if you can bring people together across the silos with a clear breakthrough ambition, I hope is that really does catalyse funding, it catalyses action, it catalyses just clarity in how we can work together on that, because it's everyone's problem.
So that's your hope for the outcomes of the report, or did you see some of the?
Yes, I think so. I think clear, uniting goals that we can get behind, that are One Health, and then people can play their role in it, but it's just it's a complex problem, and it needs complex solutions. And I think the other thing is the kind of community ownership and the voice and being spoken about, and data and everything informing decisions better is also a key part of what's hopefully going to come out of this week.
One day, can you describe very quickly what it looks like from a patient perspective? Indeed, because that'd be good for us to hear that. And also, the African Union launched a Continental Landmark report on AMR, and clearly articulating African priorities. If you can tell a bit more about that, you just touched on it earlier in your answer, but if you can give a couple concrete examples of solutions that could and should be implemented quickly, that'd be great. So the patient perspective very quickly, and how it looks like, and then some of your key measures that you're recommending.
I think for the patient perspective, for over a decade, we've kept it very sort of technical. I think now is the time to empower the patients to say, what is your expectation when you go to your physician? First of all, you deserve clean hospitals. That way, infection prevention and control is stronger. But also, what do you demand? I mean, I'm sick, I go to a physician. I have the option to say, I want to get tested before you prescribe me antibiotics. So I think we are now empowering the patient with the right information in terms of what they need to do. And that's how we can keep our government accountable. Because at the end of the day, I can call for clean hospitals all I want, but it's all dependent on the average African to say, well, it is my right to get clean hospitals. It is my right to have clean water running in those hospitals. And that way we can encourage the physicians, the veterinarians to actually drive behavior change for better interventions. I think very quickly to talk about a few things that we are calling for is NAPs have been developed post the first high-level meeting. We have developed national action plans. But in the African continent, despite that, less than 5% is currently being funded. We need to have a bit of sustainable financing. NAPs are going to be NAPs on paper. They're just going to be documents if we don't have the right resources to be able to implement those interventions. It's also expanding sort of surveillance. Currently, of course, Africa bears the highest burden, but we don't even have enough surveillance to be able to document the problem. So I'm definitely sure the problem is way worse than we are describing. And there's a need for us to have that coordinated One Health surveillance. In addition to that, it's really around what I've said before. I'm very keen to have global inequities addressed. We need to ensure that the child has the right antibiotic at the right time. And how can we do that? We need to have equitable access to medical commodities, vaccines, diagnostics, as well as antibiotics. And really tying down one major thing that we are calling for. LMICs we know that there are certain cost-effective interventions. IPC wash, biosecurity, good animal husbandry, vaccines can potentially reduce infections. When we reduce antibiotics, when we reduce the picture at the end of the day, it lowers AMR across the world, not just in Africa. So those are sort of the key things that we're calling for. And of course, bringing it to the highest level of policymakers so that they can actually do something.
We'll talk about the doing soon, but
so you can just look on the Africa CDC website, and tomorrow we actually have an event 3 to 5 at the AU building. It's the permanent mission to the African Union. I don't know where, but it's somewhere. And that's what we'll be talking about. So we welcome everyone to join us, get involved in the work that the Africa CDC is doing to safeguard the health of Africans.
Great, thank you. And so, Fiona, I'd like to go back to you on the doing part. How do we get there? How GSK and similar organizations can convene international partners? I know you have this amazing partnership with AmrefHealthAfrica, and how does it work? And what do you recommend for these international partnerships to drive more action in Africa specifically?
Thank you. So GSK obviously is a science-based pharmaceutical company. Our major contribution is through our innovation. So it's our new medicines and our new vaccines. That's the kind of core thing of what we do. And then access initiatives alongside that. So we work with Gavi on vaccines. And I don't know if people saw, there was an announcement last week of some funding we've given to GARD-P to set up a pooled procurement mechanism potentially for antibiotics, early stages. But if that works, that would be amazing. So that's what we do. But we know that science alone is not enough. And without behavioural change, as you've been saying, people demanding more than all the science is in vain. And that's why we value and love our 35-year partnership with AmrefHealthAfrica, and most recently a program that we're working with on them, which has been really to go out and listen to voices of the community, but also local politicians and One Health, veterinary surgeons, and everyone to actually understand really the current needs and gaps in Africa. I mean, you know it as well, but every bit helps, right? And that's not been published, but there's just kind of three points I'd like to raise from what we've seen so far, which is just a food for thought maybe in the next conversations that we have. May I? So the first one is about the role of communities and patients, as you've said, and some of the data that we've seen is great. So 72% of people, I think, agreed they needed to finish their antibiotic course, but 75% expect an antibiotic for a cold. So there's data there. Healthcare workers are brilliant and really clear the role that healthcare promoters can play if they're funded. The second is around better data to make better decisions, and that's a global problem for everything everyone does. But you were saying about the national action plans not being fully funded. How are you deciding? How are countries deciding what to prioritize? And the more data like this and data that others are putting together, the better. And the final thing, my last comment, is that I think it's also taught me that as it's an everyone problem, not just a science problem, I think everyone here and online and back home has a role to play here, either through your organisation or through you personally. And that might be just going and talking to your children's school about AMR. It might be funding amazing organisations like AMREF. It might be setting up your own programmes. And I think that's the call to action I'd like to leave us with as we listen to the next speakers. We all have a role to play. Just don't let that role be to do nothing.
Great. Thank you so much. This is great. And a 35-year partnership. This is amazing. And then we'll hear about some of the solutions that have been, helped to scale through this partnership. So we've worked with the colleagues at AMREF to bring some of their local partners and community-led responses. And that's what we'll talk about now. And then that's a panel that will be led by my fantastic colleague, Rumbi Chakamba, who's one of the Devex editors who writes on these issues regularly. And after this session on local solutions, we'll have a closing remarks by Dr. Gitinji Gitahi from AMREF, who's here in the room as well. Okay, thank you so much for your time and your partnership.
Thank you.
Many thanks, Alex. We'll get straight to it. Rumbi Chakamba, the floor is yours. Please welcome your next guests.
Thank you so much, Richard. And thank you, Alex, Fiona, and One Day. That was really interesting. I want to call to stage my next panelist, which is Vivian Nabasire, who is the head of the Research Thematic Group and a FAMSA representative, as well as a member of the African Youth AMR Alliance Task Force, and Margaret Odera, who's a community health promoter with the Ministry of Health in Kenya. thank you both for joining me today. We were expecting a fourth speaker, but unfortunately, a third speaker, but unfortunately, he's unable to join us. So we've got an all-woman panel today, which is fun. Thank you. So to start off this panel, I've actually been going back and forth about how to start off this panel because I want to start off with a confession. But I was thinking to myself, is this the best space to confess this? Because I'm surrounded by health experts. So please, no judgment after this. So I think, you see, I'm like, okay, I will say I have probably misused or overused antibiotics. As an adult, I get tonsillitis, which is annoying. The first time it happened, I went to my doctor, was examined. He prescribed antibiotics and pain meds. Second time it happened, I did the same thing, prescribed antibiotics and pain meds. Third time it happened, I went to the mirror, I examined myself, concluded that I have tonsillitis. I went to my pharmacist and asked for antibiotics and pain meds, and I got them over the counter. I just cut out the middleman. I knew I was taking a shortcut, but I did not understand the dangers that were associated with it. Like the report that came out last week from the Lancet shows that between 2025 actually and 2050, 39.1 million people are going to have 39.1 million deaths attributed to AMR, and then there'll be an extra 169 million associated with AMR. So I didn't understand how dangerous this is, but I knew I was taking a shortcut. So I want to start with you, Margaret. As a community health worker, you're out there working with the community. How many Roombys do you come across? People who feel like, I know what's wrong with me, and I know how to fix this, and I need an antibiotic.
Yes, a lot of people in my community. I man more than 100 houses in Mathare North slums. And yes, it is the same in my community that people, we don't have actually the knowledge of this AMR. We have very little knowledge about AMR in my community. So, and I want to clarify that AMR is a very, very recent term to community health workers. So I think from here we are going to need training so that we may pass this message to the community at large for awareness. Thank you.
Thank you so much. So one thing that you've highlighted there is the need for training community health workers so that they can pass on the message and inform people about AMR. Vivian, I want to turn to you because you're here representing younger populations, and we assume that you'll be able to do better. How important is it for us to include younger people in this conversation and to ensure that they are also aware?
Thank you so much for the question. I think this is a very important question because youth participation in AMR and other health issues is often overlooked, but it's very important because, first of all, when you look at the African population, almost 60% is youth, young people. And when we overlook this, when we leave out young people, we are leaving out majority of the population. So it's very important that we include young people, and also the fact that young people are going to be here in the long term. So when we choose to say we are going to have these sustainable solutions for AMR, we are going to have these strategies, we have to include young people because these young people are going to be here at the end of the time, maybe when some other people are not here anymore. Young people are going to be here, and young people are going to be the drivers of AMR. If today we do not tell them about AMR, if they're not aware of this, if they don't know what Rumbi knows at the moment that she did not know before, they're going to be drivers in the future. And AMR will not stop if we do not include young people. And that's why it's very important.
And then when we're thinking about young people, what strategies work when you're trying to engage them and inform them? And maybe you can give us some examples from the Task Force Alliance.
Yes. So when we talk about young people and teaching them about AMR, creating awareness, we need to use other young people because peers are going to listen to their peers. So what works well is using other young people through maybe student clubs. In different universities, student clubs are being set up, and these are like platforms for students in these universities to learn about AMR, to create awareness among other young people as well. And then we go outside to the young people that are not actually in school. And we also talk to them about it through their community leaders and setting up platforms like outreaches where they can get to know about it. And then the other thing that has worked really well is multidisciplinary action involving all kinds of fields. Now, let me talk about especially the One Health fields: veterinary, environmental sciences, and then the health sciences. So we bring them together, and I think a very important aspect when it comes to involving young people in the multidisciplinary action kind of thing is the curriculum, for those in school anyway. The curriculum, really putting AMR in the curriculum is very important. For example, I'm a medical student at Macquarie University, and of course, they talk about AMR in the medical education, but it's like a lecture. So if you miss that lecture, AMR, no. You'll find it on the word, and you may not have as much information as you need. So we need to be very intentional about teaching in schools, and that is for the young people that are still in school. Then for the young professionals that are still that are now out of school but they're practicing, we need to have the continuous medical education for them, not just medical, for veterinary and also environmental sciences, and not leaving out the other fields like engineering, social sciences. And this is something that we emphasize when we establish student clubs. We try to make sure that we're not just focusing on the scientific colleges sort of thing. We are actually bringing in even the social sciences students, because they are all candidates for AMR, for these resistant organisms to come and attack them. They're candidates and they're going to be a part of the future. They're going to create families, and they need to know about AMR so that they can create families that can take action.
Thank you so much. Margaret, I want to jump back to you. One thing that you mentioned is the need to educate community health workers on AMR. Have you seen any efforts to do that? And if so, can you tell us a little bit more about that? And then once we jump from educating community health workers, how then do you as a community health worker pass on this message to the community? And are you seeing efforts to already start doing that? And what's the best way in order for you to make this knowledge available in your community?
Okay, thank you. First of all, I will start by what are the drivers of this AMR. We need to know what really caused this AMR. And one of the drivers of AMR is economic reasons in Africa. I'm going to give an example of a client who had TB, a 36-year-old man who was diagnosed of TB. And a few weeks later, after starting TB medication, the man disappeared he became a defaulter. So upon going to his house looking for him, we did not find him. We found that he has already relocated. Then 3 months later, the man was brought back to the hospital with his friends. He was even not able to walk. He was so sick that he could not even manage himself. And we had to refer him to a hospital called Mbagadi Hospital because Mathare North had no wards. And when we referred him there, he was put on oxygen in ICU, and afterwards he was tested again, and he was diagnosed with MDR TB, dermatillomycin drug-resistant TB, and he got treated. He started treatment immediately with a second-line TB treatment, which is more expensive than the first line. And after that, after 2 weeks later, he was brought back to Mathare North Health Center, and he had to show us where he had relocated. And upon doing the contact tracing, we found out that he had already infected 2 neighbors, 2 more people now with the MDR. When the test was done, it was found out that the MDR TB had already spread in the neighborhood, in his neighborhood, and we had to start treatment which is more expensive. So the drugs are more rare than the line 1 drug, and so this prompted me to think about the community health workers being trained so that they may sensitize the community, because AMR is really a new term. And then another example is a woman who was found to be HIV positive, a pregnant woman, and she was put in care. And then after some time, she gave birth. Well, she gave birth to twin girls. But later on, she started deteriorating. So when the viral load was taken, it was 4 million copies. And we were wondering, why are the drugs failing? So we came to realize that she was not taking drugs. At one moment, she went to the church and she was prayed for, because so religious factors also come in. She went, and because of the misunderstanding, she was prayed for and left ARVs. And then after some time, when she came back, after counseling, she told us the truth, that she was prayed for and she was not taking ARVs. So first line failed. She had to be taken to a second line, and the second line did not work. It did not work. Unfortunately, the young mother passed away, leaving behind 18-month-old twin girls. So it was so devastating even for the family. So it has an economic impact. It also had a psychological impact. And with that, the role that community health workers play, we can play a better role if we have training, because honestly, we don't have this awareness of this AMR at the community level. We know we are aware of the MDR TB, we are aware of the HIV going to the second line, but AMR as concerning malaria and other diseases, we don't have that clear knowledge of it. So we need training. And also one of the things that I've come to realize, in the electronic community health information system, ICHIS, we don't have it as a part of patient assessment. So it is very important that it is even added there, so that when a community health worker goes to the households, there is that flag, there is that column that makes me as a community health worker to follow up, to have a follow up, to know if there is any MDR or AMR in the community or not. Yeah, so we need a lot of training. It needs to be integrated in the ICHIS, the electronic health information system. We also need supported supervision, because this is a new term to us. We need supported supervision from a professional who knows more about AMR. So when we have this supported supervision, we will be able to detect and respond, and also create awareness in a more efficient way. Yeah, so my role will be efficient. I will play an efficient role if I am supervised, if I am supplied, even with placards, I am supplied with flyers that helps me to educate the people in my community.
Thank you so much, Margaret. I feel like that's such a wonderful breakdown of like how AMR actually like plays a role like at a community level and how you actually see it. And I think that's also one of the issues that we have this term AMR, and it sounds so jargony when you put it like in full antimicrobial resistance. Whenever I discuss it like in a meeting with colleagues, it's always like, what is that? What is that? And I think like as you've listed out, getting that education to community health workers, getting that support. And I know we've got quite a few partners in the room, so I hope that your plea is going to ears that are open and there's an understanding of what community health workers need. So Vivian, I also want to turn to you, because I think Margaret has highlighted the support that she needs or that community health workers need. But what support would the youth need, like in this fight against AMR? And what would you like to see from government and other partners?
Thank you for the question. One very important aspect of what the youth need from the governments, the other partners, one, we need to have them understand meaningful youth participation. Because sometimes we have organizations, governments saying they are including the youth, and maybe they are inviting them to a conference to sit and and listen in, and they have not been part of the whole thing. They have not been part of the agenda setting. They have not been part of the decision making, and also they're not going to be part of the implementation. So we have 3 different levels of participation that the youth can be involved in. We need the governments and other organizations to know that youth can be involved in this and they can set those platforms for them. That is 1. 2, we need the government to be accountable for the goals they set. For example, youth participation. We need them to say that this is how we have included the youth. This is how we are doing it, and to actually mean it, set targets and to do it. We also need them to be accountable for other different policies that they make. For example, the national action plans. We need them to be able to explain that they're actually doing what they're supposed to do. Because if it's not done, it's the youth that are going to suffer in the long run. It is us who are going to stay here to see what the future holds. And of course, it's not going to be a good future if we are not acting at the moment. So we need government to be held accountable and to also give us those results that we need from them. We need them to prioritize health. We need them to listen to us, and we need them to act. And third, we need the government to build our capacity, because as young people, if we are not taught, we will not learn. So we need to they can build our capacity through training programs. And I think I mentioned a bit of this for the youth in school. They can work on the curriculum, because I know this is under the government. They can work on them and work with institutions to make sure that youth, all kinds of youth in the One Health disciplines are taught AMR effectively and efficiently. And for the young people that are out there in the working world, so that they can be able to learn about AMR, workshops, trainings for the young people to know about AMR. Thank you.
Thank you so much. And I just want to highlight that we're going to have a chance to ask our panelists questions. This is to both sets of panelists. If you've got any question, you can think about it. In just a few minutes, we'll be turning to the audience for questions. But I wanted to turn back to both of you, Vivian and Margaret. As we are all aware, there is a high-level meeting on AMR happening on Thursday. People say that AMR is a silent pandemic, but I feel like if we had $1 for every time we said AMR this week alone, we might raise quite a large sum of money. So AMR is on the forefront. With leaders discussing it at ANGA. What would each of you want to see coming out of this high-level meeting, and what would make the resolution that comes out of this meaningful within the community or meaningful to the youth? I'll start with you, Margaret.
Okay, as a community health worker, my call is the role of community health workers should be defined in policy and in guidelines, so that we may find a place, and we may find a duty to play, a role to play in a more clear, in a more stronger way concerning this AMR. I think policy should also change. Because I believe that AMR has been just been a discussion of a high-level health system, I can say, from doctors, nurses, pharmacists. So it has not come down to community health workers. Yes, we know that HIV and TB can develop into MDR TB, but I think we need a deeper training. So I call upon the leaders who are here to invest in the training of community health workers concerning AMR. For me, when I hear about AMR, I hear it like a very new, something very new. And this goes, I am an example of other community health workers who have not been trained, who have not received the training on AMR. Thank you.
I'm just going to go back to you because I think you might, I'm not sure, maybe there's a leading question, but I'm not sure if you want to add something onto that list. You speak about community health workers having defined roles within the agreement. I imagine that also requires some sort of resources. What resources would you want to come towards community health workers?
Okay, resources like training, resources like protective gear. We need PPEs when you go out to the communities. The community that I come from, we have acute shortage of water. So if the government is going to be supported to get these resources, because maybe the government is willing, have a goodwill for supporting us, but they are economically maybe derailed. So my call is for funders who are here to support the government and encourage the government to support us to get resources like these placards. Yeah, we attend to communities. Sometimes they are communities who know their languages. They don't go into systems. They just know how to communicate with their language, with their pictures and their languages. So it is very important for us as we are migrating to electronic. Let us remember that there are communities in far to reach African countries and counties that has not yet reached the level of using data, using phones. So it's very important to fund the government financially so that they will help the community health workers and assist in educating the community health workers who are in far to reach places to make sure that we control the AMR. Clearly, it is a silent killer, yes, and when we detect it when it is already too late. The people are very sick, and it is hard to bring them back to their feet. So economic assistance from funders is actually needed to bring funding to the community level at the grassroots. As they say, that outbreaks and pandemics starts and stops in the community. AMR also will start and stop in the community, and it is a silent killer that spreads very slowly right now because people are not discussing about it the way they have discussed about HIV and TB. So really, I believe that it is something that is of great concern, and the funders should put their funding there. Thank you.
Thank you so much. That's such an important point. I think one day said earlier that AMR probably kills more people than HIV, TB, and malaria. And if you go to any community and ask them what is HIV, what is TB, what is malaria, we have an understanding of what that is. But if we were to ask what AMR is, I think that would be such a different question, which is a really important point. So Vivian, I want to go to you as well. What do you want to see come out of this high-level meeting on AMR, and how will it make sure that the youth is included?
Thank you so much for that question. So I actually think that when it comes to just young people, we want to make sure that AMR is prioritized, like as a big topic, because at the end of the day, when it's not talked about, when it's not prioritized, we the young people are the ones going to suffer. So what do we want to see? We want to see that all the targets for AMR are actually put in place and they are achieved at the end of the day. We want to see commitment to these targets by all the member organizations. We want to make sure that they can also understand where the youth come in. We want to have defined structures where youth can come in. But by these governments that are going to be there, we want to make sure that they can be able to fit us in there, but at the same time, be able to prioritize AMR as a goal, be able to prioritize animal health as well, and be able to prioritize human health at the end of the day. Have these targets set and work towards achieving them. Thank you.
Thank you so much for highlighting that. I think our conversation has been so focused on human health because of the work that both of you do, but then it's always important to bring in that one health aspect to everything. At this point, I am going to open up to questions. If you have a question for any of our panelists who were here before, that is Fiona and One Day, you can also ask that. We'll make sure to get a mic to them, as well as a question for Vivian and Margaret. Any questions? There's someone at the back there.
Good afternoon. My name is Mo. I'm an independent consultant. The first UN high-level meeting on AMR was held in 2016. What's changed? What's new? What's different? Thank you.
Thank you so much. I think there was one, yes, right there.
Hi there, thank you so much. My name's Meredith Leston and I come from the University of Oxford. I'm also based within a disease surveillance centre called the Royal College of General Practitioners Research and Surveillance Centre. We've been seeing great success with incorporating point of care tests within primary care, specifically when it comes to antimicrobial resistance, just weeding out at the first level whether a disease that's presenting particularly respiratory conditions, whether it's viral or bacterial. So I was just wondering whether panelists were also excited by the prospect of point of care testing and what we can do from a market shaping perspective in scaling out those capabilities, because I think at the end of the day, although we know that this mission of disease surveillance, particularly along One Health lines and unlocking access to diagnostic capabilities, we can all agree this is urgent, but it's further off, and there are things that we could be doing now at the community level, including point of care tests, which are available today, but we just need to be thinking about who really that buck starts and stops with in terms of making that a reality. So thank you.
Thank you. And okay, one more.
Thank you. My name is Kofi Nyami. I work for MSH. I really don't have a question, but I just want to comment and applaud the panel because there's a comment that you made which says AMR will start and stop in the community. And I love that. The issue about AMR is not about institutions, it's about the people. And the fact that there are conditions that drive them to do that. And so, yes, it may need money, but if we keep talking about it, as you are saying, as we involve the community workers, as we involve the youth, they have the social media. Once we start talking about it, we will make a difference. If we keep focusing on solving AMR with us, the health workers in the institutions, we are going to fail. It actually starts and stops in the community. Thank you so much.
Thank you so much. I think I'll jump into the questions here and try and spread them around. First, I'll go into point of care tests. I will start with a question for you, Margaret. Are you seeing this at the community level? Are you using point of care tests?
Okay, for now we are not using the care ticks. And one thing I want to say, I can see change. As a person was asking from 2016, what changed? Because in 2016 you had the first meeting, of which I believe that a community health worker was not involved in that meeting, because I had it today that 2016 you had a meeting about AMR. And if we don't involve the community health workers in sitting like this, that is a very big gap that needs to be taken care of. Because if AMR goes to the community, then why should it be discussed with an absence of the community health worker who is right there in the community? So that I'm very glad, because today I'm here and that is a change. Thank you.
Thank you so much. Vivian, I'll jump to you. Do you have anything to add around point of care tests? Is this something that you're excited about? And then also, in addition to that, what's changed since 2016?
Thank you so much. I think point of care testing is also very important when it comes to AMR and disease prevention and control in particular. And I think it's something that should be put in place and implemented a bit more in our African communities. And the question regarding what has changed, I think what has changed is there. For example, we've had more countries developing national action plans on AMR, but then at the same time, I cannot say that there has been greater impact all the way from 2016 to 2024 now. Because if you noticed, many African countries actually created AMR action plans, but when they ended, some ended in 2021, and right now there is no AMR action plan at all. And there was no evaluation of the work that was done after the 2021 period ended. So I think there is really more to do. We need to come from just writing all these strategies to actually implementing them and evaluating them steadily and being very intentional about it. Right now, I'm Ugandan, so Uganda just completed its national action plan last year, and they're working on creating one right now. We remain hopeful that we can actually have it come out, because there are countries that just stopped at that level, and that is not a way forward, really. We need to work on making sure that this is a sustainable thing. Maybe if you had a national action plan all the way from 2017 to 2021, evaluate the work that has been done. Make sure you can see what has worked and what has not worked, so that in the next in the next action plan, we can actually put more recommendations to improve what could be done and set better targets, maybe with surveillance or maybe with optimization of AMR, of antibiotic use. So I think something has been done, but it has not been as impactful as it can be.
And thank you so much. I also want to turn to one day and ask about point of care tests. Are we seeing them and how can we get them in Africa? And also, in addition to that, maybe you can just weigh in on what's changed since the 2016 meeting.
So one of the things that we are advocating for is better access to diagnostics, and this is where the point of care testing really comes into play. I think beyond just creating access, when you think about things like pooled procurement, is also making a strong case for local manufacturing of those diagnostics on the African continent. That's the best way for us to be able to get it to Africans. So that is going to be a big changer in increasing access to diagnostics. But I think if you ask me what has changed since the last meeting, is African voices are now being heard. I think we can say categorically it was a significant moment in 2016, but now you can see a lot of African countries. I believe in the closed session, a lot of our ministers, our leadership will be given the priorities of the African continent. I think for a continent that is greatly affected by AMR, for the first time, our voices are right at the front of the agenda, and that is significant progress for us. Thank you.
Thank you so much, Wande. Fiona, I just want to jump to you as well, just to hear what you think has changed from 2016.
Can I answer the other question, actually,
Yeah.
just very quickly? Only because as a company with a pipeline of antibiotics, and some of them new mechanism of action, this lack of a point of care test is really challenging, because you don't want to launch a new antibiotic without being able to actually test for susceptibility and make sure you're keeping it. So I think it's a really good point, and I agree with that. And I have nothing to add other than I think many more community voices and ownership of people everywhere have come into the AMR debate since 2016, which is a brilliant thing.
Thank you so much. And for those who are interested in the African priorities, my colleague Sarah Jerving did a wonderful article on Africa CDC's priorities at the high-level meeting. And one of my other colleagues, Catherine Davison, just did a wonderful article on LMIC priorities. So if you read both of those, they will give you a rundown. Thank you so much. I'm going to hand over to Richard.
Many thanks. Many thanks, Rumbi, Vivian, Margaret, for that fascinating conversation, packed with insights from the communities in which you're working. Really appreciated it. Now, to wrap up and to help us reflect on our conversation today, I'd like to welcome to the stage Dr. Gitinji Gitahi, CEO of AmrefHealthAfrica. Gitinji, where are you? Come to the stage, please. Welcome. I'm really interested to hear what stood out for you in that conversation, and what you'd like policymakers, practitioners, funders to take forward to Thursday's high-level meeting. I'll give you the floor in this mic.
Okay.
Gitinji.
Well, that's working. Hello. Yes. Good afternoon, everybody. I'm one of those guys that Vivian said will not be there by the time this becomes a big problem. Vivian, no offense at all. But I just want to reflect on some of the things that have actually been raised. And I thank you to our partners, GSK and Devex, for having us talk about this. So just a few quick reflections. I think that I don't know how many of us have read a book called Homo Deus by Noah Harari. If you have. It's a phenomenal book. So if you get a chance, please read it. And in this book, Noah starts by looking at what were the largest problems of the world in the 13th, 14th, 15th, 17th century. And he talks about three things. He talks about famine, war, and plague. And he then goes on to reflect on each one of them. And for the purpose of this meeting, he talks about plague as follows. He says, in the face of plague, the authorities were completely helpless in the face of calamity. Except for organizing mass prayers and processions, they had no idea how to stop the spread of epidemics, let alone cure them. Until the modern era, humans blamed diseases on bad air, malicious demons, and angry gods, and did not suspect the existence of bacteria and viruses. People readily believed in angels and fairies, but they could not imagine that a tiny organism could actually be the deadly predator. But by 1918, Fleming, penicillin, the game changed completely. And we had innovators like GSK and others that actually took up the role of research and development and got us to where we are today, where we felt safe that if somebody got an infection, they could be treated. You knew it was, when I was growing up, you knew that if you had an infection, your mother took you to the local dispensary, you were treated, and you went home. But are we now, with 39 million people projected to die by 2050, are we actually facing the challenges of the 13th, 14th century? Is that where we are? Because it looks as right now, I think somebody asked what the difference is between the resolution of 2016 and this one, and has been answered by Margaret. It is more participatory. There was actually a multi-stakeholder hearing for this particular one. Other than, of course, that the first one was 5 pages, and the one of tomorrow is 11 pages, so it's bigger. There's more wording, and I hope that more wording, as you heard from the people here, means more action, because as we've seen for the UN declarations, the more words you have, the less we are saying. So I'm hoping that actually this particular declaration we are going to will reflect the views of Fiona here, Dr. Ewande, Vivian, Margaret, and reflect the views that were given by the multi-stakeholder hearing, that actually there is a solution. There's a solution, and that solution is with the people, because ultimately it's about the people. And when I listened to the panels here, I had several contributions. The first is that there's a big problem of lack of access to health services. That is the baseline. When my mother, who lives in a small village in the center of Kenya, is unwell and cannot reach me, she calls her, because she's 89 now, so she has some help around her. She says, please go to the local dispensary, the local pharmacy, and get me something. And they will go to the local pharmacy, and somebody will come home with, well, at that point, some form of antibiotic. More often than not, a local or generic of an antibiotic, where you're not sure the efficacy is actually proper. There are no proper strategies of pharmacovigilance. So you're not sure of the quality of what she gets, but she'll get it, and she will use it. And she will use it, and maybe because it was just a viral infection, it'll go away halfway through, maybe 3 days later, and about 2-3 days of antibiotics will remain. And the next day on Sunday, her fellow church woman or male comes home to visit, and they have lunch and says, hey, I've been coughing. And she says, oh, I actually have some medicines that helped me, and hands over the 2 days of the remaining antibiotic that she didn't need in the first place to her fellow churchman or woman who came to visit her. That can be said to be, and somebody said this, people are not doing this because they want to. It's actually, the system is set up for this. If you have only 46% of the Africa's population with access to health services, what do we expect 54% to do? To send somebody to the local chemists, to visit the local herbalists, or to try and use whatever is available that somebody else may have. So my mother in this case is actually a dispensing pharmacist, because that's who is available to the person who came to visit her. So deep down, and listening to the panel here, is actually a lack of services. And I think the more we push for achievement of universal health coverage, that everyone everywhere has access to the health services they need, when they need them, where they need them, without financial difficulty. And that, in a formula, is primary healthcare plus equity. That a good primary healthcare, which takes care of 80% of the people's problems, but is also equitable, meaning it's available to everybody. So the more we push our governments to achieve universal health coverage, the better for all of us. And in fact, I would like to say that UHC and primary healthcare is founded on community health systems. It's founded on what we've heard from here, from young people who are actually taking charge of their lives to be healthier, who actually influence communities. Many years ago, GSK and AmrefHealthAfrica invented, if you could call it that, a program that we used to call FACE. George, you remember. It was personal hygiene and sanitation education. And it was premised on the assumption that young people in school could be taught certain principles on health, and they could actually influence their family's behavior when they go back home. And that program was transformational. A program like those would change what we are talking about, involving young people and ensuring there is access to health services for everybody. Secondly, it's back to the basics. We know this is about water and sanitation. This is about water and sanitation, because the more people have infections, the more they're going to seek treatment or care where the care is not available. So back to the basics. I was out in the field last week in a small village in Kenya called Ikolomani, and I noticed that hygiene has actually been decommissioned. What do I mean? Since COVID, we had a lot of hand washing stations with soap and water. Many, everywhere. When you go there, all those hand washing stations are now full of cobwebs. They're actually not working because COVID ended. So we've decommissioned hygiene. We need to get back to our community health system to tell people, wash your hands with soap and water, because the less infections we have, the better. And of course, that's coupled with ensuring every child is vaccinated. And finally, it's all these issues of ensuring that are health system issues around the fact that you need surveillance, you need data, you need diagnostic equipment, point of care testing. We know we work with community health workers to do point of care testing for malaria, for example. And those policies must be tight enough to ensure that when the community health workers go to the village and they have a rapid diagnostic test and they want to test, if they actually don't have the test, they must not prescribe the anti-malaria. So again, the community health worker ownership, and I can tell you that large populations, Africa CDC is looking to get them to 2 million community health workers. They're going to be the foundation for referral, for early identification, and they must be properly equipped with what they need. And ultimately, this is about the people. It's about everybody, multi-stakeholder. Everybody needs to be on board. The Ministry of Education must be on board for us to change curriculums in schools, not only for health workers, but for everybody. Even schools need to know that actually there's a danger, so that if my mother is using an antibiotic and her grandchild is nearby, says, "Grandma, that is wrong," we need to call the nearby help. So I think for me, it's basic. And I would like to leave it there and say, thank you very much for being here with us. Thank you for your partnership. We will continue for the stewardship. We'll continue for the partnership. And each of you is welcome to continue on this journey with us, because again, we don't want to go to the 13th, 14th century where we are facing the plague and also believing in worldly gods. Thank you.
Many, many thanks, Gitinji. Thanks for that rousing call to action, that analysis. We really appreciate it. To GSK, to AMREF Health Africa's partnership, thank you very, very much in helping us to bring this conversation to the Devex stage here at UNGA 79. A big thank you and round of applause, please, for our speakers and interviewers. Thank you so much to all. And to our in-person and online audience, a big thanks to you. All that remains for me to say is to stay tuned tomorrow from 9 a.m. Eastern Time here in New York City as we kick off the first day of our Devex Summit. That's called The Future Can't Wait, Shaping Tomorrow Today. Meantime, thanks for joining and all the best from all the team here at Devex at UNGA 79. Thank you.